Well, good morning, everybody. Welcome to the ninth installment of Cosmic Coffee from here at Lowell Observatory. I'm Jeff Hall, an astronomer and the director of the observatory. Glad to have you here with us this morning. Usually we cover topics in astronomy and planetary science, but we're going to take a detour this morning, and I'm really pleased and grateful to have two experts with us to discuss the current worldwide health crisis. At bottom center, Dr. Dave Engelthaler, who's the co-director of Translational Genomics Research Institute here in Flagstaff. And at top right, Dr. Paul Keim, Regents Professor of Biology at Northern Arizona University here in Flagstaff, and actually the founder of TGen North here in town. Very quickly, first, we always like to give a quick shout out to one of our local small businesses, and we're going to say hello this morning to the good folks at well-known Dutch Brothers Coffee. Their drive-through is open and available for some tasty brew in the morning. So do go ahead and support our local businesses in these rather difficult economic times. So thanks so much, Dave and Paul, for being with us here this morning. What we'll do, we'll certainly be taking questions from our viewers, but I'd like to kind of frame this conversation in three parts. And I think the logical place to start is I'd be really interested to hear your take just on the current state and the likely immediate future of the pandemic. So the current wave in Arizona, and elsewhere, what do we expect to see over the summer? I know, Dave, you've mentioned concerns about, a second wave, and then of course the prognosis gets murkier going into 2021, but I'm sure everybody would really be interested to hear where you see things going at this point.
Sure, I'll start there, Jeff. So good morning, everybody. It's great to be here. For those of you who I haven't met before, my background is primarily in public health and infectious disease epidemiology. And so that's a large part of what we do here at TGen, and working really close with the public health departments and trying to understand this virus as it's moving around our community as well as around the world. What we're seeing now, certainly in the US, the case numbers are dropping. What's happening though is the virus is shifting, and it's moved really out of our larger population centers by and large, and more towards the center of the country. People are more spread out and spaced out, much like in the Southwest, and so we see slower movement of the virus. We don't see as many cases occurring daily as we were seeing, say, a month ago. All those things that we've been tracking are true, but they're true from a larger perspective. On a very local perspective, we will see hot spots and outbreaks that can still be devastating. But the general trends are that the infection rates are slowing, the transmission is slowing, which is good. Now, on just stepping back even a little bit further on a global perspective, the same is true. The virus has shifted, the patterns have shifted. We're seeing more cases in equatorial regions, and now more into the southern hemisphere. And this is kind of what was anticipated because, while we don't know everything about this virus and it's not well adapted to the human system, it's still primarily spread through a respiratory route. And the hot summer months tend to slow that down, and the cooler winter months tend to increase that. And that's what the southern hemisphere is starting to experience now as they get closer to their winter. It is quite likely that they're going to see more and more cases. And there's other epidemiologic trends that are occurring there as well. Here in Arizona, what we're seeing is we're actually finding more and more cases, and that's because we're doing more and more testing. Last month, we were averaging in the state about 2,000 tests a day. This is the collective we, everybody who's doing testing. Now we've been averaging for the past several weeks testing at about 10,000 tests a day. So we're just testing a whole heck of a lot more, and we're going to be continuing to find cases. But the epidemiology is also what we were expecting. This is a severe disease of those people with the high-risk conditions and the elderly. While we're seeing cases across the spectrum, the vast majority of the serious cases are in those groups. Our case fatality rate in our seniors over 65 is just about 19%. That's astronomical, and that's exactly what we were afraid of, and it's coming true. Versus if you're younger than 55, the case fatality rate is well below 1%. So 55 and younger, by and large, we're faring really well, and it is acting a lot like the flu would, and as far as the epidemiologic numbers are. We have some strange outliers, and again, that's because this virus is new to the human body, and we can find all sorts of ways to react to it. But the where we have to spend our time is on those most at-risk individuals, and it is these elderly with chronic conditions, and by and large in our long-term care facilities. And in Maricopa County, which is a little further removed from Flagstaff, 71% of deaths in Maricopa County have been associated with long-term care facilities, nursing homes. That's exactly what we were afraid of, and that's definitely what's happening. So I think as we start to open up, and we can talk about that, we really have to pay attention to the epidemiology and who do we have to protect the most, because that's who will continue to die no matter what.
Yeah, thanks, Dave. If I could add just a couple of thoughts to that excellent overview of what's going on, it's really clear that a lot of the numbers are being driven by these hot spots, either places where we have a concentration of at-risk individuals, or heaven forbid, where we have high density gathering of people, and that we get a massive increase in the transmission rate due to that then spreads out across the community. And so while we're looking at the trends around the state and across the country, it's important to remember that at a local level, at the level of our own behavior, we can actually have an effect on how this spreads. And so if we suddenly open up, and for example, if we would suddenly have the Super Bowl, and the Super Bowl had 100,000 people in it, and we had 1,000 people, or even 100 people there who had COVID-19, we would suddenly see a massive hotspot, and that would then have a big effect on the numbers. So while we look at these things on a global basis, we definitely can affect the outcome and the curve at our local level by how we behave.
Right. That's kind of what caught them in Italy, right? They just didn't know, and these big events were going on.
Yeah, that's one of those examples. It wasn't the Super Bowl, but maybe the equivalent of the Super Bowl in Northern Italy, where they had this big soccer match, championship match, lots of hugging, kissing on the cheeks and things like that. And sure enough, they had a massive explosion with devastating impact. And so those are the types of things that we just have to avoid in Arizona.
Right.
Yeah.
Okay.
Yeah, so just to add on to that real quick, Jeff, sorry. And that's a perfect point, is not only do we know who is most risk, we do know the types of things that cause the most risk. And that's a great point. And just the last piece on the epidemiology, certainly in Northern Arizona has been very different than the rest of the state. And I didn't get to this part yet, which is some of our tribal communities. We all know that the Navajo Nation has just been devastated by this for a number of reasons, more so than probably any other population other than those high-risk groups. Whereas that's not the same across all tribal communities, where we do see a tendency of higher risk conditions. Some places we've seen lots of disease, and other places we've seen none. Some places we've seen higher fatality rates, in other places we've seen lower fatality rates. So it's not even across the board with even with the communities that would tend to be higher risk. So it's just something we just don't know perfectly the epidemiology on this, but we're continuing to learn.
Excellent, excellent. And so, I mean, clearly then ultimately the way through is development of either antiviral meds or vaccines. And I know everybody is really curious as to how long that's going to take, because it's such a critical component of when we get back to whatever normal is going to mean. So where do you see those developments standing? You hear a lot of different things.
Dave, if you like, I'll take a first shot at it. So, I look at controlling COVID-19 as kind of a three-legged stool. And right now, the most important tools that we have are public health, ways that we can control the disease through social practices and our own behavior, hygiene. That's what we have in place now, and that's what people need to be really practicing. In the future, we have new drugs coming online. There's a whole series of innovative and old-fashioned approaches to improving the treatment of patients. Physicians are learning every day how to handle these patients better. In Northern Arizona, we've had hantavirus around for decades, and the survival rate in hantavirus has increased tremendously. We haven't had better drugs there. We haven't had better vaccines. And so what's really happened is physicians have just learned how to deal with the disease better, and that's improved the outcomes tremendously. But drugs are an area where there's a lot going on, and we can expect to see new drugs coming online in the next 6 months. A lot of drugs have been approved for emergency use authorization right now, so physicians can try to use them. There was a drug that came out, an antiviral drug that one of the phase 1, phase 2 trials, the results were announced, and that was given emergency use authorization. Of course, ultimately, many of us believe the way out of this is through an effective vaccine. There's over 100 different vaccines under development right now. Some of those are moving from phase 1 into phase 2. Phase 3 is where they really get the data that results in their approval by the FDA. We expect to see some of those results in the fall, early winter. So I'm actually I'm very optimistic about the vaccines, but it's important to people to remember that we're really talking about 2021 and maybe not even early 2021 when these vaccines start to be distributed. So we need to go back and remember that the public health practices and our personal behavior and hygiene is what we have for now. And that's what's got to get us through into 2021 and maybe the middle of 2021 to get out of this via the vaccines. Okay,
thanks, Paul. And I'll go sidetrack for just a bit to pose one question. We have a question from Phil Massey. Where can one find a better breakdown of the fatality rates? For instance, is a 70-year-old with no underlying conditions at significant high risk? So are those resources available online somewhere, or what's the best one of those?
Yeah, so there's a couple things. So we can look locally. The Arizona Department of Health Services is actually putting out quite a bit of data now. It took a little while, but they're making those types of data sets available. They summarize it, and then I believe some of the more detailed data can be made available upon request. But that would just be thinking about just Arizona. What we do is track a lot of these details that are being put out in different studies. So a lot of different epidemiologic descriptive studies of populations around the world to understand, those kind of fine-tuned breakdowns. We certainly can't say that everybody over 65 is equally at risk. We do know the more chronic conditions you have, the greater the risk. So one of the early studies I saw showed that individuals who are 65 and older have had one chronic condition of those lists, like the diabetes or chronic heart disease or chronic pulmonary disease, hypertension, that made it up 25% of the fatalities in that group. But if you had 2 or more of those chronic conditions, that made up 50% of the fatalities, on top of that other 25%. So we just know there's an additive effect with these different situations. We think the elderly, there's an immune system issue there, but then when you add on top other, what we'd say, comorbidities or other illnesses, it just exacerbates the situation.
All right, and we'll take, there's 2 other questions and then we'll move on to the next part of the conversation. But this is a good one from Heather Faley. I hope I pronounced that correctly. How does the overall effectiveness of a vaccine rely on the percentage of people who vaccinate?
Yeah, so this really comes back to this whole concept of herd immunity. And so if in your local community or in a global context, we have to have enough people immune so that the transmission rate drops below 1. I mean, in the end, that's what we have to get to. You know, the R0 value, which is the number of people that will get the disease on average from somebody else, is a dynamic number. It can be different in different places and different situations. So that's important to remember. And so you can have an effect on that R0 in your own community, either by vaccination, because people who are vaccinated are going to be resistant to getting the disease, maybe totally immune, maybe partially. We don't know that yet. But importantly, a combination of these public health, social distancing and hygiene practices, and a vaccine could mean that we need far fewer than 50% of the population vaccinated to bring this under control. There's no doubt that high-risk individuals I think of a grocery store clerk as being a high-risk individual, first responders, healthcare workers, and then, of course, our at-risk individuals in long-term care facilities. There's no doubt that those folks are going to need to get vaccinated quickly, and there will be some type of prioritization, and that will hopefully then start to control the disease in effective ways that don't require 100% vaccination. You know, we definitely know that we will not achieve 100% vaccination rates once the vaccine's available. There's lots of different reasons for that, between socioeconomic as well as personal beliefs out there. I will get vaccinated. You can absolutely count on that. And once I get vaccinated, I'm getting on an airplane and going and doing something fun. And the rest of you could just stay at home.
Yep. Yeah. And when it's appropriate for somebody like me to get one, I will certainly be in line too. Okay. Last question for now that I think goes back to what we were talking about a little bit before about events. And this comes from Larry Lang. Hi, Larry. Glad you're with us. He asks, do you see a way before a vaccine is here that we can have events like concerts and other live performances without social distancing?
So, you know, we definitely have had some of these conversations, Jeff, and I think certainly not without social distancing, right? So we're not going to be able to do anything without appropriate social distancing, without taking those appropriate measures that that Paul was talking about. These, you know, the things that we got to do, take care of ourselves, and the requirements on, you know, make sure there's a lot of hand sanitizing stations, and people that are at risk don't go out, and people that are sick don't go out. Is there a possibility of events? I think that there are, but in a completely different way. One, obviously, the virtual events are happening, but in-person events, to me, would have to be outdoors, and they would have to be really well distanced. So let's just say, for instance, an event at, say, the Pepsi Amphitheater. That I think that would be feasible if you have people that essentially mandatorily socially distanced, so some spacing of 10 to 20 feet between family groups, and then no groups larger than 6 to 10 that don't already live together or interact with each other. You could still have that type of event. I think outdoors is a key thing, and not crowding, and then also making sure that we're following the other public health recommendations.
Yeah, just to add to that, totally agree with what you said, Dave. You know, economically, I think there's some models that would work here. You know, boxing, not my favorite sport, but boxing has definitely made pay-per-view economic success. So, you know, I could see the Super Bowl, for example, as a pay-per-view, and then charge a small number of very wealthy people a lot of money to be there in person. Okay, so instead of having 100,000 people there, maybe have 5,000 and make those people pay a lot.
So Paul's going to get on his plane and go to the Super Bowl.
Yes.
No.
All right, let's touch on some of the things where we've seen a lot of either controversy or at least arguing. And you know, one of the things I think I've seen people asking a lot is, you know, where did this thing ultimately come from? Is this a natural evolution, say, in bats, or is this like an evil plan from a Chinese lab somewhere?
Well, as soon as you mentioned the word evil, I guess that's a question for me, Dave. So some folks may know that I've also worked a lot in science policy, especially in the area of biodefense and dual-use research. And so this is a question that has come up many, many times and I've been involved with. So there's a lot of things we know and a lot of things we don't know about this virus. One thing that we absolutely are sure of is that this is a bat virus. It's very similar to other viruses, coronaviruses that we see circulating in bats, and that it jumped from bats to humans. Now, we think that there might have been an intermediate host like the pangolin, these scaled anteaters. And the reason for that is that we find some of these same viruses there. And there was a mutational process that occurred as this virus went from bats through an intermediate host and then into humans, which involved changes in its genome, and changes in its proteins, and improved its ability to interact with human cells. And we can see that in the genome. And so the signatures of that adaptation as it jumped are clear to us. Now, we've seen this before. We see it happen with the MERS, which is a coronavirus that jumps from bats to camels to people. We saw it with SARS coronavirus 1, again, from bats to people. We see it all the time in all sorts of pathogens. This isn't something new. So we know that this emergence or this host shift from a wild animal reservoir into humans can occur. And of course, in this case, that's the default hypothesis. And so we think that that's how it happened. Now, we also know that there is a Institute of Virology in Wuhan, China, and that they've been studying bats. You know, it's inconceivable to me that the Chinese government or this institute would have released this virus in their own population with the deaths of tens of thousands of people in order to get at the United States, you know, and that's a conspiracy theory that we've heard a lot. So it's inconceivable to me that in fact this is an evil plot by the Chinese government or people to get at us. Because I've worked in the area of biological weapons and for a long time, one of the basic principles of biological weapons is you don't use it if you don't have a vaccine for it. In other words, if the Chinese had had a vaccine on January 1 and then this spread around the world, that would have been pretty suspicious. But obviously they've been hit really hard by this. So there was no overt plan here to create a weapon to spread on the world by the Chinese.
Yeah. Okay. Thanks.
Can I ask Paul a question? So Paul and I have these discussions a lot, and we know of many past instances, both in the U.S. and in China and elsewhere, where there have been accidental releases of the pathogens that are being studied, whether that is an accidental shipping it out or someone actually getting infected and leaving a facility. So that is, to me, is maybe the third possibility here, that it's, you know, it's not that either it's straight out of nature and some spillover event that there was an evil plot, or that actually was being studied and may have accidentally been released or left a facility. Paul, can you speak to that?
Yeah, that's a possibility that we can't rule out right now. I personally think that the animal jump to humans is the most likely thing that happened here. You know, the WHO and China have agreed to investigate the outbreak more thoroughly, and hopefully we get more information. You know, if it had been a laboratory accident, it's quite possible the Chinese and those scientists aren't even aware that it came out of that laboratory. But that's the type of thing that's discoverable, you know, by going into that laboratory and looking at records and looking at material that they were handling. It's very straightforward to establish a link between this COVID-19 virus and anything that was in their laboratory. So at this point in time, you know, we've got a problem on our hands that we have to solve. And so its origins is not critical. But that is definitely something that we should be looking at in the future to try to understand exactly if a laboratory accident was responsible for this.
Right. Okay. And, you know, you also, another thing we're seeing people stressing about and arguing about a lot recently are, of course, the masks and appropriate usage. You know, personally, I go out into a Flagstaff business. I mean, you mentioned the grocery cashier. You know, I religiously wear a mask in the grocery, more just to try to be respectful to that person who's got an 8-hour shift. And I always thank them for keeping things up and running for us. At the same time, you know, if I go out for a walk or I'm just on a bike ride or something, I don't wear one because there are circumstances where it seems overkill. So I think our viewers might be interested in your opinions. What's the overall efficacy of mask usage and sort of an appropriate things to do in the workplace and the community?
Let me take the first swing at that. And there's obviously been a lot of confusion around masks because the messaging has been terrible. Early on, the messaging was don't wear any masks. And the masks are only for healthcare providers and they won't work for you, which obviously confused some people because, well, why would they work for a healthcare worker and not for me? But the question was, did we have enough resources to support our healthcare workers? They absolutely needed the mask to interact with patients. Now that we're kind of past that and there are plenty of masks and mask alternatives, the recommendations come out to use those in public, especially, well, one, you shouldn't be in public if you're sick, but if you're sick, you should use a mask if you're going to be around anybody. And two, in those high traffic areas, like being in a grocery store where you're going to interact with people, even if it's socially distanced, You just don't know if someone is going to sneeze or cough at you, or you're going to sneeze or cough at them. So then the question is about efficacy. The masks themselves, so the ones that they're using in the healthcare system are really designed for effectiveness. The way that people are using them in public provides some level of lesser effectiveness. That's because, one, they haven't been trained with them, how to use them, how often to replace them, and there's a lot of makeshift masks and bandanas. So any layer that goes between your mouth and nose and someone else will provide some level of effectiveness of preventing the flow of the droplets that may contain the virus. You may have some virus in particles that are much smaller that won't be filtered out by whatever mask you're wearing, or you may not be wearing it appropriately, so it comes in around the side of the mask. But if the concern was that we had that much going on in our community and that much spread, then we wouldn't have anybody coming back out, essentially. But since we have a very low level percentage of the virus in our community right now, the risk is lower. Wearing a mask will have some additive effect, but if that's all you're doing and you're not socially distancing, you're not using the hand sanitizing and hand washing, and not keeping those at risk out of the system, then we're not going to have, it won't have any effect whatsoever. So it adds some layer. Maybe it's another 10% of protection, but it's not it is certainly not a cure-all or a silver bullet to prevent you from being infected or to prevent you from infecting someone else.
Okay. Yeah, thanks a lot, Dave. That's really helpful. Obviously we're trying to figure out what policies we're going to put in place as we start phasing people back into the workplace and so forth. So let's go work through our sort of the final topic for the conversation that I'd like to cover, and then we do have some questions that have come in on the chat feed that I will feed up. So of course now everybody is talking about isolation versus reopening. And Dave, we were at a different meeting last week that really prompted some of my thinking about this. And so, in general, for policies here at Lowell, I've tried to take a pretty conservative approach. We're pretty much still all at home and shut down, even as Arizona has begun to reopen. At the same time, I try to put myself in the shoes of a small business owner here, who's put 10, 20, 30 years of sweat and love and toil into this little emporium, and they're watching it crumble before their eyes. And, I might well be motivated to reopen. And I'm sure I would try to do that in the most respectful way I could. I mean, I don't want to get this, and I don't want my customers or residents or guests driving up from the valley. You don't want them to get it either. So there's two things to discuss here. Dave, you had some interesting comments on sort of the adverse effects of isolation. Of course, we know why we're doing it, and flatten the curve and all that. But what else is going on in here?
Yeah, so this is a complex issue, and it's definitely not just a kind of binary. Everybody stay shut in or everybody go back to normal. It is, can we start opening things up and having some interactions to help support businesses and get the economy flowing again? That's one piece. The other piece is thinking about people's mental health and physical health. If we have, if people are shut in, they're not getting really appropriate mental health or physical health, and those things have really long-term ramifications. And the mental health thing is becoming more and more interesting. Just the effects of not interacting with people like the way that we have, and the way we've evolved over the past hundreds of thousands of years as a species. A couple of months, that ain't going to kill us. But there are signs that there is increased levels of calls in for high anxiety or depression or distress into some of the mental health hotlines. We also know that there has been increased numbers of suicides. There's been increased numbers of domestic violence incidences, but they're not as well documented because people have not been able to essentially escape a house where they normally could every day. They could disappear for 10 hours and be at work and not have to be shut in with their abusers. There's increased calls into domestic violence shelters. And I can't speak to locally here in Flagstaff, this is really more of a national trend. So having people shut in, it actually does have negative public health effects too. So these things have to be balanced, and the way that we balance that is making sure that whoever opens up can open up responsibly and understands that, yeah, it is their responsibility to do the right thing here. It is absolutely, people think public health is what the government is telling us to do, and that's not it. Public health is all of us. Public health is all of us kind of stepping up and saying, if we're going to be out there in public, we're going to do the things to limit our exposure, but our exposing others as well. And if we can maintain that kind of an attitude, or build up that attitude and maintain it, I think that'll be very helpful.
Yeah, if I can just add a couple of examples, I totally agree with what Dave said there. For me, I always look at the models and the predictions for how many deaths and illnesses we're going to have. And I think one of the things that we're not modeling are things like mental health, suicides. And, we don't look at some of the other impacts of the closures, such as, how many children are going to grow up in poverty because of this, or what are the fifth grade reading levels going to be like in 2 years because of this. And so there's so many things involved here. It's important to understand it's not a plus minus type thing. I mean, right now we're not totally closed. We have essential businesses like grocery stores open, and nobody's going to ask us to close grocery stores because of some death curve that we're looking at. So we have to do this in a smart, intelligent way to maximize the impact on our activities, such as the economy, our education, and minimize the spread of disease. It's going to take some really good leadership. It's going to take some smart and intelligent choices, and not just on a national level, on a local level, because this is a disease that may be global, but it's acting on us here locally. And so we have to be making these choices and decisions on the ground here.
And I love your comment on leadership there, Paul. And I think that's absolutely it, is that this is where leadership is needed, these very tough decisions. And these are not binary choices, and they're not easy choices. Obviously, we have not been through this in our lifetimes, but we also need to look at the data that's happening. And I stressed it early on that we know who's dying from this. And even with the society really being shut down as much as possible, those people were still dying. And those are people that can be protected, especially the ones in long-term care facilities, and these people with the higher risk conditions. So I'm not even sure that those numbers would have changed all that much, even if we had opened up more, if we weren't being able to protect those individuals that are already in congregate settings, and that's not just those. There's also jail issues and other ones. So I do think there's been a lot of great work, and we're learning a lot. But I think we also still know who's at risk, and we got to build around that, and not just think that everybody's just generally at risk from dying, because by doing that, then that means that we're missing out the opportunity to protect those that will die.
Good point.
Right. Thanks. And of course, obviously, I need very little convincing to follow the data and try and do what the data tell us to do. Makes the most sense. So given that, I mean, suppose you are one of these small business owners, and what we see out there, I think, is complete information overload, right? You got a zillion websites, 60-page documents coming out of the CDC, as careful and thoughtful as they are. And everybody's like, what do I do? And I think, as with any situation like this, there's probably, just a couple, 5 to 10% of the possible actions you might take that get us 80 or 90% of the way to where we want to be. And then the rest of it kind of ties off the loose end. So what are the real tall tent poles, as I and lots of others are thinking about, how do we keep our people safe as we start phasing them back into our workplaces and businesses? The really critical tent poles that are the key elements of that responsibility you talked about.
So, Paul, do you want to start?
Sure. Dave is actually the expert in this, so I'll take a crack at it first before he steals all the low-hanging fruit on this answer. But as he's already pointed out, and we're talking about kind of a combination of in-person and virtual type of activities in the future. I think, again, every individual organization is going to have to figure out how to keep the social distancing in place and the hygiene and practices, good behavior in place for the next year at least. And I think that could be a combination of in-person and virtual type activities. Local restaurants, some of them have just been incredible as far as the takeout food. There's one of my favorite pizza places in town, which is right next to Dave's house. It has just incredible. It's like these people come out, just hand you your food and it's ready to go. And so, opening up those restaurants, it's going to have to be done very carefully. And, I think this 10 to 20 feet rule is better than a 6-foot rule when you come to sitting, especially in a closed room where those respiratory droplets can circulate. Doing activities outside makes a lot of sense to me. You've got a lot of air there to dilute out the droplets. And so that's really going to be effective, I think, at increasing the effective social distancing. And so we have to be real careful about it. And, these small businesses are going to have to make these decisions very carefully because, if they open up and then everything crashes around them, they may not have the resources to open up again. So I know that these business decisions are complex. They involve dollars and cents as well as the public health aspects.
Yeah, very great, Paul. You did take all the low-hanging fruit. I think, I know a lot of small business owners, and I know that, they've absolutely been struggling, and some just won't ever come back, and that's devastating. The ones that do are going to be the ones that are going to be able to be creative and adapt to the situation as much as possible. As Paul was talking about, innovations have to be brought in. This is just one of those things that causes disruption and destruction that then forces kind of evolution of new businesses or the way we think about it. I do know that almost to a letter, every small business owner I know absolutely cares about their customers and does not want to do anything that would put them at harm and is looking for those things that they can. And so keeping that mindset that maybe your business is like your house, and what you would do to bring people into your house and have people in there. What would be the safety things that you would do? And that would be, you're not going to bring too many people into your house at any one time. You're going to make sure that you have, if it's an indoor business, which most are, have appropriate air changes in it, so your HVAC is changing the air out, and maybe you have open doors and open windows. That absolutely helps. Having not just the customers and the staff using hand sanitizer as much as possible, almost to an overkill, but also having continual wipe down of any common touch surfaces, Clorox wipes, and showing that. And this is part of it too. There's a psychological effect on being successful here, is that you're actually showing what you're doing. People have an understanding of what you're doing, and that'll be also modeled and followed elsewhere. If you're not doing that, if you're in the news meeting, you're trying to find how everybody's doing things wrong, it's going to be very destructive. And I think that's pointing out the bar on Mill Avenue that opened up and had 100 college kids jam into a small space. That was bad. But that's not what most people are doing, and most small businesses are doing. They really do care about their customers. And so there are balances on messaging as well as showing what you're doing, so people have some level of comfort and that they're following those practices themselves.
Yeah, very good. I think that's an excellent point. And it goes back to the, part of the reason to wear the mask in the grocery store is, demonstrating that you understand the situation. Or, if I go out on a walk, and somebody's coming, I don't move out of the way subtly. I try to make a really explicit point that I'm going across the street because that's important. So as you can imagine, we've had a bunch of questions come in. I want to be respectful of everybody's time. So let's see if we can just answer some of these, and then we'll say thank you for a great session. So several questions here. So Claire Gibson would like to know, what do you think school settings will look like beyond this next semester and beyond?
Well, unlike Paul, I have 3 teenagers at home. And that's clearly we're going to have to, the school system's also going to have to evolve, and there's going to have to be more telelearning and the things that they're doing now. But there is something that we don't have time to get into it now. There's still not been any great studies to suggest that shutting down schools actually lessens the amount of disease transmission overall in a community. It seems counterintuitive, And that's why there's been a reluctance, even with some of the great, like Maricopa County, so great minds there at the health department, really trying to balance the effects of shutting down schools. However, that's already happened, that those decisions were made already. So I do think they're going to have to evolve, and hopefully we can come up with a 21st century style of learning now that we're being forced to.
Yeah, not much to add to that. I mean, some type of a hybrid approach in the future where more stuff is done virtually, but then also then coming up with ways to get students into the classroom in low density fashions for the maximum impact when they need to have hands-on activities. And so, I am not a teacher. I would not want to be one to tell a teacher how to do their job, because I know they know how to do it much better than I do. But some type of creative hybrid approach is obviously going to be necessary.
Okay, thanks a lot. And I think you hit on a critical point there, Dave, for not only this situation, but science in general. Things come up that seem incredibly counterintuitive, right? Like this issue with the schools. And I think we have a natural tendency, if it doesn't match what we perceive to be real, we reject it. Well, that can't be, that's counterintuitive. But counterintuitive stuff happens. And when the data lead us that direction, usually good things happen. Here's a really good question from Pagilsi that we didn't get to before, but maybe we should have. Is it known how often the virus passes through touching of surfaces? There's so much effort being put into sanitizing groceries, et cetera. Truly necessary?
That is a really good one. So we absolutely know that the virus can survive in the environment and can survive on surfaces. And this is one thing we didn't truly appreciate, how long this particular virus can survive on different types of surfaces and under what conditions. And we're learning that. From what is understood and what CDC is saying and other studies have shown, the vast majority of all transmissions are still going to be airborne. But this virus, still being new to us, seems to can cause infections in different ways. And we don't know all the routes of transmission. We do know that it can be shed through the gastrointestinal tract. And so it can be, live virus can be harvested from stool samples. And that's seemingly unusual. We know that you can certainly pick it up and get it on you from the environment, but does that actually end up causing an infection? For some other respiratory viruses, absolutely that can. You get it on your hand, you touch your eye, your nose, your mouth, you can get infected that way, and it's quite likely that that's possible, and certainly is possible. But do we know how important that is? We do not.
Okay. All right, thanks a lot. Paul, do you want to add something?
That's a good answer. I have nothing to add.
Okay. There's one question about a specific schedule for opening up Lowell Observatory, and I'll just quickly address that and say we are currently operating our research telescopes. But at the moment, I've given the staff guidance to expect to be at home at least until June 1, and our visitor program, I can't imagine opening before July 1, and even that will be subject to seeing how the caseloads go, just trying to be careful about it. So Daniel Brent asks, where does the data on staying 6 feet away come from, and what is the confidence level that that's sufficient as opposed to something like measles where it lingers in the air for hours?
Paul, do you want to start there?
Well, so I actually don't know where that number 6 feet came from, but I can tell you that when I think of my space around me these days, I think of it in terms of probability curves. So I know that if I'm 1 foot, 2 feet away from somebody who's talking, the probability that I'm going to get infected, if they are infected, goes way, way up. And so if I can stay further than 6 feet away, I do so. Jeff, as you mentioned, walking across the street when you meet somebody on the urban trail or when you're walking makes a lot of sense. So maximum distance that you can achieve, 6 foot should be considered the minimum distance, in my opinion. But again, I'm not sure exactly where those numbers came from or how they're supported by data, Dave.
Yeah, so the 6 foot comes from early modeling and understanding how droplets that are expelled out of the body during a cough or sneeze, how fast most droplets, and it's a probability curve, how fast most droplets actually fall out of space. And that would be under kind of standard conditions. Where you're indoors and you don't have wind movement and you would have normal kind of air change situation. 6 feet is going to limit the majority of direct droplet transmission that way. 10 feet, you're going to reduce even a lot more, so your probability of transmission goes even further down. So that's absolutely true. The other piece to know about this is also time. So just a quick interaction passing by somebody is much different than you sitting in a room with somebody for an hour and sharing their air. So there are multiple things at play there, but that's where the distance came from, some of that early modeling about how long droplets stay in the air and fall out, as opposed to just small virus particles such as in measles, which can easily stay in the air and move around, which is why we have such a higher transmission rate with measles than almost anything else.
Excellent. And then, that's exactly what we're trying to do here. I mean, you can do the math easily enough. It's just arithmetic. If two people are talking in an office and you know the volume and you know the rate of virus in and a half-life for existence in the air, you can really get those probabilities and give very sensible mathematical based guidance on what makes sense and what's, overkill. And you don't need to just burden people with unnecessary precautions. So thanks. There was a question about when we should wear masks in public. We covered that. Mary Kershaw, hi Mary. Mary asks, attractions serve many visitors from outside the area. We don't know where people are visiting from. Is there increased risk in such a mixed population, and are there special measures we should take?
So here's the thing is that the virus, not yet, but soon is going to be really found in every corner of the globe. And the risks actually change depending on the week or the month. And so, for instance, a risk of a traveler from New York a month ago is much higher than it is today. But that fluctuates pretty quickly and across space. I don't think that we could legitimately say that somebody from a certain part of the country or a certain part of the globe is at higher risk of transmitting to us at this point in time. That's definitely, certainly was different back in January. Travelers from Hubei, China, absolutely had the greatest risk in the world of transmitting around the world than some from some other place. But now that the virus is found in all continents and in most countries, the geographic space risk-based modeling is probably not useful for understanding who's at risk in your work environment.
Yeah, and just to follow up on that, we certainly need to avoid any type of social injustice or xenophobic reactions. There are a lot of stories early on about Asian Americans being discriminated against because it was from Wuhan, China. And that was just ridiculous. And we need to avoid that type of a prejudice because, as Dave says, I mean, the virus is out there. What's a good practice for people in Flagstaff remains a good practice if that person comes in from Italy.
Okay, thanks. So at this point, I want to keep this to an hour and be respectful of your extremely busy schedule. So we've got 5 more questions queued up, and we'll take those, and then we'll wrap the session. So one, Sherry Schaefer asks, "Hi Sherry, my spouse is high risk. I am not. If I follow the recommended practices, is it okay for me to go out and meet people? Also, I tend to meet with older people, so would I be putting them at risk too?"
So I have parents at home that are they've been shut in by and large, and they're both in their late 70s, or my dad's 80, and certainly in that high risk category for more than one reason. And I still cannot go and visit with them in their house or hug them, and I'm going to maintain that. That they did come for instance, they came for a visit, but everybody stayed out on the porch and socially distanced, and we're able to do that. But if you have a high risk member at home, you have to take extreme precautions that you're not exposing yourself and bringing something back in, because again, we know who's at most risk for getting serious disease and death. And so that's part of it. Yeah, it sucks for those individuals, but they're going to have to really limit their exposure to other individuals at this point in time.
Yeah, I totally second that. If you're living with a high-risk person and you have to be living in close proximity to them because of caregiving or other situations, you then accept the responsibility for them, and you can't go out to Mill Street bars, for example, not that you would have, and come back to a person like that, because you're the conduit then to the community. And so you have to take on that additional restrictions and responsibilities.
Thanks. Larry Lang asks, Paul, have you been advising Dr. Cheng on reopening? Do you feel confident that NAU will be able to have on-campus classes in the fall?
I certainly have been giving her advice on things that I can give her advice on, which has to do with infectious diseases. There's a lot of moving pieces about bringing students back on campus. The entire environment, management environment, healthcare environment around COVID-19 changes on a weekly basis. And so, again, this is a place where strong leaders are going to come to the forefront, and they have to be able to develop plans that are flexible and can move with the context of what's happening. So I do have confidence in President Chang's ability to do that. Exactly what she's going to do, I'm waiting to see as well.
Okay, thanks. Here's a good question from Mary Kershaw. I have been told states that have opened already over the past month have not seen significant spikes in infections. Is this accurate?
It's really hard to try to link any individual cases or even trends in cases right now to reopening that's been happening over the past couple of weeks. It's too early really to even see and understand those trends. So I've heard those reports too, and I've heard the opposite, that states that have reopened are now seeing devastating numbers of cases. I don't think either of those are completely true, and only from the perspective of we don't know that yet. What we do know is we get more people interacting, there will be more disease transmission. There's no doubt about that. However, is that something that we absolutely need to prevent, or do we need to prevent disease transmissions to those that are at greatest risk as the rest of us try to keep society going, and also increasing, kind of overall exposure and herd immunity? We're not going to, as Paul said, that vaccine's not going to be available this fall, and there likely could be a big second wave. There could be lots of little waves and focal outbreaks along the way, and we still have to try to do our best to limit the impact of those things on those individuals that are going to have to go to the hospital or unfortunately die from this.
Yeah, thanks, Dave. That's really good. I've been finding myself having this sort of slightly fatalistic hypothetical going through my brain. Absent a vaccine, the only way to build the immunity is to do it the hard way. And actually, you've just pointed directly towards the next question in mentioning a wave. This is coming in from Ruben Hayes. Hi, Ruben. Hope you're well. How likely is a second wave this fall? And would the world's apparent lack of interest, almost fed up with the virus at this point, affect the outcome of a second wave?
Let me start on that, just because I've been focusing a lot on this, but I'm sure Paul has some thoughts too. That this is a respiratory virus, and while we've never seen it go through a full year before. There is a seasonal effect on respiratory viruses, and we do see those drop off, but that also means that they come back. So along the way, those types of viruses, they sometimes go into quiescence, or sometimes they're just lingering in the background and cause little spikes here and there. We anticipate that there will be spikes. There will absolutely be greater spikes in more cases if we get into a sense of complacency and we don't keep our guard up. And I do think that there will be a second wave that is much harsher than what we've experienced already. And that's just because the virus is already out there. It's already everywhere, as opposed to it took multiple months for this to get everywhere. But it's now around in our communities. And when the conditions are right and things promote transmission, it will absolutely happen faster and probably harder than it did before. The good news, though, is that our healthcare system, by and large, handled what we did or what we've been through. There's been certainly problems, say, like with our neighbors on the Navajo Nation and hospitals supporting them specifically as they went through their tragedy over the past couple of months. But by and large, the hospitals in the Phoenix and Tucson area, where the most cases and the most people are, fared really well and had room to spare. So that's good as we get hopefully some more drugs in our toolkit and some other things to respond to this as a second wave may come.
Yeah, nothing really to add except to say that, yeah, this is not going away. We're going to be seeing it come and go. It's going to be very dynamic, and there's going to be lots of different factors. And you can think of it as just sitting out there and waiting for us to make a major mistake where it can take advantage of the situation. Again, having a large, high density type of events is just going to be ripe for something bad.
Mm-hmm. Right. Thanks a lot. And that's just going right in line with the way my thinking's been going as we start to think about reopening Lowell. This is not going anywhere. You can't shut down the world economy for a year. You just can't. So we've got to do the smartest thing. And as you point out, be rigorous about keeping our guard up. And there was another thing I was going to mention earlier in the show. This is our 9th Cosmic Coffee. So we're 9 weeks in. The novelty of it, for lack of a better word, is worn off, and everybody's getting sick of it. But you got to keep your guard up and be rigorous about these basic practices. Okay, last question. This is actually also a really good question coming in from Joyce Binney. Is it possible that multiple minimal exposures, which do not result in symptoms, will develop immunity in healthy individuals? And I might actually add a corollary to that. What is the viral load that you think you need to get infected? I've read anything from like 1,000, 2,000. How does this all work?
I don't think we know the infectious dose yet, do we, Dave?
No.
Nope. I mean, that really isn't known. There are other examples out there of where low doses of pathogens can lead to some type of immunity. You can almost think of it as a booster shot when you get your vaccines. We know that herpes virus, for example, those types of exposures can actually increase immunity. All I can say is I wouldn't want to count on it. There's no data on this yet. We do know that people who have full-blown disease and even mild symptoms with lots of virus production are producing lots of antibodies. We don't know yet exactly what that means from a protection standpoint, but there's very promising data from animals that says higher levels of antibodies result in higher immunity. So while there's a lot of things we don't know, I'd say there's a lot of data that's pointing towards good immunity for people who have had the disease before, and there's good immunity from some of the vaccine trials that are starting off, at least from the animal studies. Okay, well, thanks a lot. We're coming right up on an hour. So, I just want to say thank you both so much. A global pandemic is certainly not the least busy time in the lives of pathogen experts. So we really appreciate your taking the time. And I think you can tell from the volume of questions, I'm sure this was very helpful for our viewers. We will be back next week. My guest next week will be the Lowell Observatory trustee, Lowell Putnam, because it will be our 126th anniversary next Thursday. I'd also like to note that as we struggle through the financial impacts of our prolonged shutdown, memberships and gifts to Lowell Observatory help us keep going. I will mention that TGen, I believe, is also a nonprofit and benefits from the support of generous individuals as well. So you can directly help the critical work that Drs. Keim and Engelthaler are doing. So thanks so much. Thanks for joining us. As always, stay vigilant, keep your guard up, stay healthy, stay safe. All the best to all of you from all of us here at Lowell Observatory. See you next week.